Pathology from a prestigious King George Medical College, and I'm delighted to be standing here today to be discussing a very unique case with all of you, which is Gala-positive essential thrombocythemia in a Philadelphia-positive chronic myeloid leukemia patient. So what happened was, a 55-year-old male patient came to the medicine OPD with the complaints of generalized weakness, abdominal distension, loss of appetite, and loose stools since 2 months. And on the examination, on physical examination, mild hepatomegaly and moderate splenomegaly was noted. The workup was done for the patient, and and the CBC showed a reduced hemoglobin. TLC at that moment was 1.6 lakhs with 6% blasts and 4% basophils. Platelets at that incident were 7.5 lakhs, and GBP showed mild anisocoagulocytosis with microcytic hypochromic picture. So USG was suggestive of mild hepatomegaly and moderate splenomegaly. And the liver function tests showed mild increase in the alkaline phosphatase and mild increase in the total bilirubin of the patient. Bone marrow aspiration at that moment was not done, and based on the peripheral smear findings, BCR-ABL1 quantitative PCR was advised, which actually turned out to be positive, showing the international scale of 11.9%. So based on the above investigations, patient was diagnosed as CML chronic phase. Patient was then started on tablet dasatinib 100 mg OD along with other symptomatic relief medication. In March 2023, due to incontractable diarrhea, the dasatinib dose was further reduced to 50 mg OD, and to which patient showed a good compliance. So regular follow-up for the patient was done, and patient showed good compliance to the treatment and actually attained better clinical condition. And follow-up BCR-ABL transcripts for the patient was done, which in March 2021 at the time of diagnosis was 11.91%. In August 2023, it was 1.361%. And to our delight, in October 2024, it came out to be not detected. So the patient achieved complete cytogenetic remission by October 2024. But despite effective treatment for CML and complete cytogenetic remission, patient's platelet counts escalated to 15 lakhs per microliter, which again necessitated the further need for evaluation of any other myeloproliferative neoplasm. So we did the follow-up for the patient, and we called the patient again to analyze for the persistent thrombocytosis. So the patient was called. Was clinically stable, he had no complaints, and he was continuing his treatment of dasatinib very well. And he came to our lab, we analyzed him for the persistent thrombocytosis. So CBC at that moment again showed reduced hemoglobin and neutrophilic leukocytosis. Platelets at that moment were 12 lakhs again. So bone marrow examination was performed, which revealed increased megakaryocytes in clusters, hyperlobated form, dwarf form, and staghorn megakaryocytes, and blast cells only constitute 2% of marrow-nucleated cells. The biopsy performed then was consistent with the BMA findings, showed hypercellularity for H with clusters of megakaryocytes, dwarf megakaryocytes, and staghorn forms. We also performed the IHC of CD34, which again showed scattered blast cells. So, as we can see in the picture, large clusters of platelets. So it's actually obscuring the field. It is that amount. And the megakaryocytes can be observed, large megakaryocytes, hyperlobated megakaryocytes, which are actually showing staghorn branching. That can be observed in this picture. This is the bone marrow imprint. Round megakaryocytes can be observed, the dwarf megakaryocytes, whereas on the right side, bone marrow biopsy shows large clusters of megakaryocytes. And at the bottom, we can see IHC CD34, which again reveals scattered blast cells. So on the basis of these findings, MPN mutation panel was advised. And actually, actually which turned out, which showed BCR-ABL not detected, JAK2 mutation not detected, MPL not detected, but CALR mutation was detected.
To our right, counts are still consistent at 11.5 lakh, but we are hoping that the cytoreduction would take some time. The patient is still continuing the above mentioned treatment, and we are hoping that the cytoreduction would happen with time. But the findings actually enforce the need for much research, for thorough research and better treatment modality for dual positive cases. Let's see myeloproliferative neoplasms. So the JAK2 mutation was actually discovered in 2005, MPL mutation was discovered in 2006, and CALR mutation was discovered in 2013. And initially all these mutations along with BCR-ABL rearrangement were considered mutually exclusive events. But according to recent research, we have come to realize that rare cases of concomitant occurrence exist among these mutations. A thorough review of literature was done, which involved 3 isolated case reports and 1 meta-analysis, and we actually came to the conclusion that this occurrence is so rare that only 24 cases exist world over as of now of a concomitant occurrence of a Philadelphia positive myeloproliferative neoplasm and a Philadelphia negative myeloproliferative neoplasm. So much so that our case is actually the first case in our country which showed transition from CML to essential thrombocythemia. Discussing the concomitants of CML and ET, the combination of these or alongside any other Philadelphia negative MPL, complicating the diagnostic process. So developing effective protocols for patients for both mutations is essential today. Persistent, also one take-home message for us pathologists is that if we encounter persistent thrombocytosis in a chronic myeloid leukemia patient, we should actually think about essential thrombocythemia from now on. So persistent thrombocytosis in a CML patient on TKI therapy requires molecular screening for Philadelphia negative MPLs. So rather than just going for BCR-ABL1 mutation, we should actually consider MPL mutation panel if we encounter persistent thrombocytosis in a chronic myeloid leukemia patient. Treatment modalities. So the treatment options till now for CALR mutant MPNs were hydroxyurea, anagrelide and interferon. They may be effective, but their efficacy after CML or for dual positive cases still remains uncertain. Allogenic hematopoietic stem cell transplantation has actually given very promising result, and in the literature so far only 1 case has been reported for dual positive cases which actually attained complete remission, which was cured of the disease. And so to optimize patient outcomes, it is essential to develop collaborative strategies for maintaining dual mutations. So again, our take-home message would be to do a thorough research and to develop new modalities so that we would be able to handle dual positive cases in a better manner. We would be able to give better patient care, early patient treatment. Thank you so much.
Thank you, ma'am, for your interesting presentation. Now, we have with us our guest speaker, Professor Manoj Jain sir, Head of Department, SGPGIMS, Lucknow. Sir is an expert in renal pathology, transplant pathology and surgical pathology. Sir is also former President of Indian Society of Renal and Transplantation Pathology, Council Member of International Academy of Pathology. Sir has over 170 research publications. So let's dive into the realm of innovation and technology with an insightful lecture on artificial intelligence in a diagnostic pathology, opportunities and challenges. I welcome you, sir, to enlighten us on this emerging topic.
Thank you. At the outset, I respected Anita Mehta, respected US sir, all my dear colleagues, friends and juniors. It is very nostalgic moment for me because I started my journey from this very hall. I'm a medical career in 1981. KP Bhar was principal that time and he was taking our introductory class that time. I started my journey from this hall only. And so I'll be discussing, it's a great honor to me, Dr. Yas Singh invited me, it's a great honor for me to deliver this talk. So recently our institute got NIA plus scoring 3.2. So if we see artificial intelligence in diagnostic pathology role, it has come up in a big way. So what I'll be overview of anatomical pathology, conventional versus what are the differences in conventional and digital microscopy, whole slide imaging, image analysis in pathology, then use of artificial intelligence and computational pathology, then application of AI in diagnostic pathology, and what are the opportunities. Challenges because we all have to cope up with this what AI is coming in our routine day-to-day practice. So if we see surgical or anatomical pathology, because in diagnostic pathology major component is anatomical pathology. So it's a visual science, we have to deal with lot of images. There are glass slides, as you are all aware, glass slide images, microscope images. We have to see on lower magnification, at higher magnification, and lot of features, just like this is a case of urothelial carcinoma. In low magnification, we will be seeing the architecture, invasion, and then necrosis, and on higher magnification, we will be seeing nuclear irregularity. So, lot of features we have to see by screening the slide on the microscope. So, if you see processes in anatomical pathology, see anatomical pathology, initially it was just processing of the sample, slide preparation, staining and viewing under a microscope with different stains. Later on, as the advent of the digital pathology, which has taken computational pathology, digital image acquisition, then came whole slide imaging, and then later on, with as advancement of the computer science, then image analysis and artificial intelligence took up. So if you see the difference between routine microscopy and digital microscopy, in routine microscopy, just you require a microscope, put the glass slide there, screen at low and high magnification, one slide at a time you will be seeing there, and there is a burden of archival and retrieval is very difficult there, and it's a piece of puzzle, just you have to see all these and then collate the finding. In digital microscopy, via computer, we capture the image, analyze by software algorithms, instant archival retrieval is possible, can be viewed anywhere, telepathology is possible, digital teleconsultation is possible, and this can be integrated with laboratory information system. And so if we see we have completed the concept of digital, we want special in digital image, just like circumference area measurement, all things can be done. So this was just capturing multiple images from the digital microscope. Later on, with advancement, whole slide imager or virtual slide came, in which just like digital glass slide, it is converted to whole slide image. This is just like you see Google Map, you can zoom, unzoom. Similarly, glass slide, you can zoom at different magnification. Whatever area you wish, you can zoom and you see. For this, you require whole slide imager, which is at present the cost is exorbitant, but now cost is just day by day coming down. And it represents a high resolution replica of original glass slide. And with software, this can be manipulated. So this has revolutionized the whole field of digital pathology and artificial intelligence. This is the milestone and landmark trial in computational pathology. So as computer develop advancement in software and hardware and the computer develop, apart from that, microscopy also developed. So in computerized microscopy, digital imaging was long back in 1986. Deep learning, machine learning and deep learning came, then convolutional neural network came, that I'll be coming, and then whole slide imaging software introduced. Now this Philips, this whole slide imager was FDA approved, and there are now some algorithm softwares for tumor detection which has been FDA approved. So this is the concept of image analysis. So it's just extraction. Volume, diameter, contour of the nuclei, then whatever the nuclear surface, some DNA content, you can, by cytometry, densitometry or fluorometry, you can see the content of the DNA and the nuclei, just seeing the intensity with various strains. Then pattern recognition, in which human being were good, computer were lacking, now artificial intelligence has taken up that also. So just like glomeruli, you can say diameter, you can measure, you can circumference. In any calibrated image can be manipulated with help of the software. This is the process how this works, this extraction of meaningful numerical information from the picture. So image calibrated image has to be taken, then region of interest has to be selected, then image optimization, then thresholding, then these are the processes in which image segmentation is done, image is converted to binary digit, then edge detection, and quantify area of interest you can quantify. So this all has taken up later on, this is incorporated in the artificial intelligence. So a lot of applications in morphometry, linear distance measurement in calibrated image can be, area fraction can be measured, size and shape of the object, mean nuclear volume, just like megaloblastic anemia can be quantified based on this morphometry. Then objective counting, mitotic count you can do with K67 algorithm. Similarly, in this, because of different immunohistochemical stain, whatever the nuclei are there, they can be quantified based on their pixel counting. They can be quantified, and they can numerically they can be graded. Different cell compartments. So later on, with advancement after the digital imaging and this image analysis, then artificial intelligence came into existence. And this, as you know, in every artificial intelligence is a current topic in social media everywhere, because all softwares in computer, whatever the website will go, artificial intelligence is working there. So this is a broad area of computer science that makes machines seem like that have human intelligence. Software that mimics models human judgment. So there are broad applications in day-to-day life, problem solving, task completion, visual perception, speech recognition, decision making, language translation. Similarly, in diagnostic field, this has also taken up in a big way. So if you see, artificial intelligence is an umbrella term in which computers are made just like human thing. Computers are programmed in such a way that they behave like human. It's an artificial intelligence. Then this was a program. Later on, without clear programming, it was seen that machine learning, the computer repeatedly some task is given to the computer. So without clearly programmed, they were performing the same tasks. That was the machine learning. Then came a neural network, deep neural network. That was deep learning. In this, multiple hidden layers were prepared in which input data is given, and with computation this pooling method, they were giving the outputs with that. So machine learning was in artificial intelligence. Machine learning was sub part of artificial intelligence. In this, computers can learn from the data as humans learn from the experience and make decisions about new data without human interaction. So they were just without human interface, they were learning the data and giving the desired output. So machine learning was used mathematical option to process input data resulting. So there were two types of learning, this supervised learning and unsupervised. Initially they were taught that these are the mitochondria, these are the mitochondria, computer learns. Later on you view that image, they will tell that these are the mitochondria. With further advancement, machine learning, this deep learning or artificial neural network came into existence, in which there were some input layers. They require large annotated data because here data has to be annotated, labeled data, you give the computer, and then there are multiple hidden layers in between, which is called black box, and then they give some output. Suppose you are labeled data, you are that this is the tumor, some type of tumor. So multiple images you are given there, and then output with computation with hidden layer, this will give that this is the tumor. So early layers, for example, are used. So initial layers are just in this are used for input data, and later layers are the output. So early layers, for example, are used to extract features, whereas later layer they are used to information to make predictions. So they are used for the pattern recognition, classification, and prediction. So there are different learning strategies for the convolutional neural network. So they train from the scratch. Suppose this flower is there. We are just training the computer that this is a flower. So multiple hidden layer are there. This will just made it patches of this picture, and every patch will be detected in that, and then with combination of this, that this is the flower. This will tell. Then if you pre-trained model, you load a lot of pre-trained model. So you don't require later on train from scratch. Just last layer you train, and it will be computer or trained. Then you can do fine-tune network in there. So how this principle of convolutional network works, every image, that's the difference between machine learning and deep learning. In deep learning, image is just broken into multiple patches. And each patch, there are some digits are there. So just pooling and unpooling, average pooling, they will make it at a binary digit. And then this will come to conclusion that this patch belongs to malignancy or this belongs to whatever the question is given, this will resolve. So in supervised learning, there are two types, machine learning and convolutional neural network. In standard machine learning, the whole image is given there, annotated image, that this image correspond to malignancy. Their features will be extracted. In between, hidden layer will be there, and then it will classify, automate, detect, segment, all these processes will be done. Whereas in CNN, that is supervised CNN, that is convolutional deep learning. In this, image will be broken into multiple patches, and these patches will be segregated for benign and malignant. And then just based on the pooling layer, this will say that this image belongs to malignancy or this image belongs to benign. In weakly supervised, there's already program data is there. They start from the previous data, and this just image is given that this is malignant, this is benign. And with graph construction learning, this will come to result. This is a bit software IT based, so I'll not be able to tell in much detail this. If you see their application in our diagnostic pathology of AI is enormous. Prostate cancer detection has already FDA approved software page, a website has come. You can send their image and they will Gleason grading and those will come with
help of artificial intelligence, that FDA-approved software has come. Some breast cancer, lung cancer, enormous all cancer, hepatobiliary pathology, renal pathology, automation, immunohistochemistry, KI67, thresholding, say ERPR, HER2/neu, everywhere this role is there. Gene mutation prediction, tumor detection for molecular analysis. So I was just coming a few papers because there are subtle morphological features on the which human eye cannot perceive. But based on this pattern recognition model, they can predict, just like in this paper in ovarian cancer, their BRCA prediction based on morphology, they are predicting BRCA mutation based on just morphology, based on deep interactive learning basis. Similarly, lot of role in every subspecialty pathology field, just like in renal pathology, if you want to quantify interstitial fibrosis, tubular atrophy, glomerular size, or you can automate amyloid detection, whatever you have. There are a lot of computational techniques are available, and programs are being developed based on AI, which can automatically detect disease staging can be done, grading can be done, classification can be done, then prediction of the survival can be done based on the image analysis. So this is the depiction of AI and machine learning approaches currently used by pathologists. They can automatically detect mitosis, detect intratumoral heterogeneity, they can detect Gleason grading, they can do detection of lymph node metastasis, cell segmentation, detection and quantification can be done based on the AI. So a lot of development has taken it in prostate cancer, Gleason grading. This paper came in 2019 for the development and validation of deep learning algorithm for improving Gleason stage, coding of the prostate cancer. This is the first FDA-approved AI-based pathology product for prostate cancer detection, page of website. So later, now more and more solutions they are coming, they are available, in which just you whole slide image, just you send to them, and they will stage and grade based on the AI process. So if you see, artificial intelligence in diagnostic pathology has enormous role. There are a lot of opportunities because every pathologist, whatever pathologist, old timer or new timer, everyone has to learn this technology, and because this is the future of pathology. So it has potential to revolutionize digital pathology and diagnostic pathology practice. Significant opportunity across various aspects, maybe quality control, maybe sample receiving, integration with HIS. In every aspect, reporting, prediction of the disease, everywhere artificial intelligence is coming in a big way. So there's enhanced, whatever you are seeing under the microscope, there were inter-observer variation, there is optical illusion, then here improved detection. So whatever the subtle changes, morphological features which human eye cannot perceive, they can be quantified with computational technique, and more accurate diagnosis of disease like cancer, they can be offered. And there is reduced inter-observer variability. Rare diseases can be detected with the help of artificial intelligence. Just putting the glass slide, whole slide imaging, one can do a lot of things. Then increased efficiency and productivity in the laboratories. Whatever the automation, just like mitotic count, area count, or semi-quantitative grading, what we were doing in the microscope, under the microscope, they were taking time-consuming, labor-intensive, so those tasks can be taken by the artificial intelligence. Then faster turnaround time, whatever, because we are taking time to analyze and writing report, those parts can be taken up by the artificial intelligence. There is remote consultation, second opinion, telepathology, they all are possible. Remote teaching, connecting various medical colleges with spoke and hub model from the center, teaching whatever rare case can be taught, consultation can be sought from the different centers. So those all things are possible with help of digital imaging, telepathology, and artificial intelligence. The advancements in research and development, that it has got much role in. These are the opportunities which AI and digital pathology and computational pathology will offer. So drug discovery and development, artificial intelligence can drug discovery and development, the large set of data is there. So with whole clinical scenario, clinical condition, so whatever the drug discovery, what is the response of the medicine, that all can be predicted in this. Then personalized medicine, because whatever the tumor under the microscope we are seeing now, molecular is further subclassifying these diseases. So what are the subtle changes are there on the microscopy, they can be correlated with morphological changes. So maybe whatever with molecular analysis we are achieving, some part this AI can take up in routine histopathology that can tell that is a BRCA mutated tumor is there, or in colon cancer, this is MLH1, MSI instability tumor is there or not. Those all can be taken up by the AI. Then improved understanding of the disease, a lot of role in the research also. Then quality assurance and control, improved quality control. AI algorithm can be used to identify and flag potential error of inconsistent pathology reports. This is in laboratory medicine, whatever the hematology or clinical chemistry reports we are getting, there's a lot of role they can be done. Then continuous learning and improvement. AI model can be continuously trained and updated with new data, because as diseases are evolving, their treatment therapeutic modalities are coming up. So AI also will go along with that. And there will be continuous improvement in, and this will define the diagnostic accuracy. And with pace of the human being, it will take up very fast, all these things. So everything is looking very rosy, but it's not like that. There are a lot of challenges in AI practice. If we see, right from starting staining, slide cutting, whatever the good digital whole slide image you have got, because that's the initial phase. So if your routine slide, staining, cutting, section quality, everything is, then only you can get good quality of whole slide image on which AI will work. So data quality and quantity. So lack of harmonized standards of AI. Just like in radiology practice, if you see, their DICOM protocol, everything is defined. Here our pathology images, digital pathology images, those things are not defined. The lack of adoption of current imaging standards for digital pathology, just like in radiology. Lack of high quality annotated data sets, crucial for training, and accurate, because annotation, ultimately whatever we are feeding the computer, we will get output. So only human has to interface with all that. So high quality annotated data will be required for the crucial training of AI algorithms. Then hardware and computational, lack of robust IT infrastructures, including whole slide scanners, because there is prohibitive cost of whole slide imager. Starting from 20-30 lakh, they move to 3-4 crores. They are currently cost for whole slide imager. Then lack of explainable AI, because there are hidden layer. Whatever we are in artificial neural network, whatever feeding in the computer, there are many hidden layer in which just with various permutation combination, pooling and pooling data is derived. That is called black box. So there is a lack of trust with that, because we are not sure what we are getting, because everything is not very transparent. Then clinical and technical, inexperienced laboratory workforce, because we all have to learn this, with pace, we all have to learn this AI and digital pathology in our routine practice. So many AI models are black boxes, making it difficult to understand how they arrive to their decisions. Then lack this transparency can lead to trust issues among pathologists who need to understand and justify the AI recommendations. Then there are ethical and regulatory concerns also, data privacy, informed consent, the potential of bias for artificial intelligence algorithms are significant ethical concerns. Then robust regulatory framework are needed to ensure that AI tools are safe, effective, and used responsibly in clinical settings. Then addressing these challenges is crucial for the successful integration of AI in digital pathology routine practice. So if we see this AI technology can be used to support the overall reporting system. This can speed up our reporting system, make more precise and accuracy, then measure morphobiological features more objectively. Whatever features we are molecularly we are driving, those subtle changes can be picked up based on AI. Then AI added reporting will enable pathologists to focus on challenging cases, because they will have time to focus on the cases where more input is required, clinical discussion, clinical details. So whatever the mundane job of the pathologist, AI can take up with those jobs, with increasing workload demand for the pathology laboratories. So artificial intelligence and digital pathology in pathology not replace, just everyone is scared that job will go for pathologist job. Everyone is just discussing that AI will take up our jobs. So it's not like that, because whatever the empathy and whatever intelligence, human intelligence, no one can beat that. That will always remain superior. So it's not to replace the human resources, including pathologists, laboratory, but it will provide to support them. So AI, artificial intelligence will not replace human intelligence, but they will redefine a role of human beings as a pathologist, as a human being, with advent of the AI in our routine day-to-day practice. So that we have to all accept that AI has to come in our day-to-day practice, and we have to take it very positively. Thanks.
Thank you so much, sir, for accepting our invite for this Foundation Day. And sir is so readily available to give us his knowledge. And sir, if we'll be happy to take up any questions. And my question from my side is, sir, will any time, what is your prediction, will any time AI replace pathologists?
That's what my concluding remark, AI will never replace, because whatever human intelligence, because whatever we are feeding will just, it will improve our efficiencies and accuracy, efficiencies, those it will be improved. But as everything is evolving, disease process, with the advent of the treatment, disease course, disease, everything is changing. So AI will help in all those, just early detection, they are quantifying. But ultimate, whatever human intelligence, empathy, concern for the patient, socioeconomic issues, those things AI cannot take up, because only human can take up.
AI will overtake human intelligence, because human intelligence is personalized. And what the AI will do will make a shared intelligence. So that way, average intelligence of a person versus AI will be much more, especially for screening the large masses. So that advantage we will have, because what may be, I may be good, but only at a location for few slides. But if so many of the people with the principle of the science, they have put their intelligence religiously, and it is being shared intelligence, like the Sanatan Dharam. So that it will definitely enlighten, like just from the smell of the skin, just from the look of the skin, the machine can make thousands of the divisions and the classifications, and can, without any biases, can say that this is the group, highest risk group in which we should go and investigate that. So that advantage will be. And if you see all the war, or for that matter, anything which is happening in the world, they are now basically not human, but by AI, like the landing of this, all the missiles, we are going to the space, AI, AI, AI.
But in diagnostic pathology, AI will only do whatever the task it's given. It's just tubular, whatever we are doing.
No,
it will not see side by side.
No, we will make questions like screen for thalassemia minor, just on the observation of the skin color, or on height, or all these parameters, and then you analyze. Now that type of the analysis can only a machine can do. As we are saying that this is the work of the IT or IIT people, they will be doing. But for AI, this biology, or for that matter, this thing, IIT or arts will not remain different subjects. We can all pull down. And of course, with the everything, considering everything that it is logical, and definitely it will be better. Like if you see in judiciary, if this comes, what will be the speed of the delivery? Because even if we are good in justice, but delay. We are good in histopathology, but delay in reporting. Affordability, everything. So AI, something comes which is better. You will survive because of the betterment. The human, we become better because we shared with books, with so many, likewise the AI. So this thing, it is a warning sign for all the pathologists to be very aware. And all these जो आपके जो पहले के पढ़ाई है ना, you are old model, 15 साल बाद रिटायर होना पड़ेगा, नए नए बच्चे आएंगे, वो समझ पाएंगे जी.
There will be, but whatever the human empathy, concern for the patient, those things AI will never take up, because human, whatever we are as a social responsibility, AI will not take up that.
It is just the ज्ञान. आप अज्ञानी हैं तो आप कुछ नहीं कर सकते हैं. ज्ञान है तो मंत्रों से कर सकते हैं. तो we will have to accept it.
We have to, it will
Good,
balance.
good. Good, sir. हम ऐसे पूछ लेते हैं. One question from my side. You have put this photograph, okay? Just see, he's a robot.
This is robot.
But we don't want robot. Intervention is a must. Okay, we are doctor, we are a clinical pathologist, so that should not be replaced by any robot, first thing. Second, just see there are opportunities and challenges by AI, okay? More than 100 pathologists are produced at Lucknow at least. And in whole UP, more than 1,000, I must say. What are the challenges once they are going to start their practice as a solo laboratory owner? So how it is going to help and what is the challenges? Because it is applicable in the big setup like institutions. Volume-based work is going on. There AI can be useful. But what about the solo labs? MD pathologists just going to establish their own lab and the cost is too much. Is there anything that you can say to young pathologists, those who are going to establish their own lab, how they can apply this artificial intelligence?
Definitely, just like in software, is seeing lot of apps are coming in on mobile. Similarly, AI pathology related apps, AI related apps will come. They will help in their efficiencies, their output efficiency. Those everything will be taken up by those AI. Even in smaller lab, everyone will have something from AI interface with AI.
I am Dr. Raj from neurology. So what we are talking about, basically of super AI. There is an imminent danger that if machines are become more intelligent than human beings, and even Stephen Hawking's state after 20, 30 years. So if you make the machines more intelligent, and if there is some integration of emotions, so they can surpass human intelligence. But it is not going to happen. We hope so. But it is a debatable question. Because AI is of three types: narrow AI, general AI, and super AI. So we are basically at the level of general AI where we are training the machines. So machines are supplementing us in our day-to-day, I mean to say, this medical treatment and diagnosis, right? So as far as this, I mean to say, usage of AI is concerned, we all are using AI now with the help of chatbot. You see, yesterday only, the DeepSeek, it was from China, a latest chatbot that was launched in the world, and whole of the America was shattered that we were the king of this chatbot. How China, with the minimal pouring of funds, makes such type of chatbot. Thank you very much.
AI will redefine our role as a human. That has to come, because we have to adopt AI in our day-to-day lives.
So just 2 lines. With time, with age, the technology always advances. So what I personally feel is that we should not try to hide from that fact. Rather than we should train ourselves fair enough and better enough to be a part of that world, because whenever new technology comes, we have a concept in our head that everything is going to be taken away, our jobs will be going to be taken away. Same thing happened when the computers were introduced in India. A large section of the society thought so. But what happens with time is job shifting change place. So it is very important for all of us as a pathologist to not to deny the fact that this is something which is coming next, and how we can train ourselves and increase our skill with the passing time to be a part of it and to actually incorporate AI in our lives in a way that still we have a significance in dealing with it. Because a machine can only be as intelligent as the person who is sitting right in front of the machine using it. So this is something, so it is better that we technologically advance ourselves and we increase our skill with passing time and be a part of that landscape and that future.
I think there are 4 words important, fundamental 4 words for this. One is data, data analysis. Number second is basically making models, algorithms, and finally predictive analysis. These are the fundamentals of artificial intelligence. It requires a lot of hard work from all the sides. It's not only the role of, I mean to say, medical professionals, the domain experts, engineers, those who are having sufficient knowledge about R programming, Python, because you have to extract the data from or import the data from their libraries. Thank you.
This innovativeness, whatever human being have, the AI will never take up. Innovativeness, ideas, innovativeness, those will come only with human intelligence.
Yes, what I feel, it's AI is not artificial intelligence, it is acquired intelligence.
Yes.
We as doctors, whatever we feed into the machine, it learns that. And finally, it gives the result depending on that. So I feel we can take the help of AI in our work, but eventually it will not replace the doctors.
My saying is that the artificial intelligence is a misnomer.
It's an acquired
It's
intelligence.
artificial.
I mean, better and large masses screening. What do you mean? No. What do you mean by replacement? Like for the mass killing, AI is very good. For the mass screening, it is very good. For mass teaching, it is very good. You may be very good surgeon, but suppose there is a AI-derived robotic surgery being done from USA and surgery being performed here. What is the problem about the FACO and all that? That all can be done. That is being done on the system. Like we are doing AI in the chemical pathology, biochemistry, the person is, some flaw is there and the Bombay person is correcting that. So it is not we are not, in real sense, we are already dependent on the AI, and the AI is misnomer, that I agree. It is human intelligence which should be given, which has been generously given for the uses, better uses or worse uses as you can.
What he said, acquired intelligence. It is the acquired intelligence.
Acquired means that I have acquired. No, I know this, but the earlier, the best persons, what has happened? We say that अंग्रेज लोग ठीक नहीं होते. अंग्रेजों ने सारी किताबें लिखी और उसको लिपिबद्ध किया, उसी को हम पढ़ते हैं. हमारे सारे जितने भी हैं कहते हैं भारत में पता नहीं क्या हो जाता था, पत्ते से ऑपरेशन हो जाता था. तो पत्ता वाला ऑपरेशन है कहाँ, लिटरेचर कहाँ है, हम कैसे पाएं? तो वो जेनरोसिटी नहीं है, केवल इंटेलिजेंस होने से नहीं है, वो ग्रेस कहाँ है, नहीं है, वो ऑरा नहीं है.
I think, sir, discussion can go on at lunchtime. Thank you, sir, for this enlightening session. As we turn our focus to the advancement in laboratory automation and digitalization, I now invite our respected Professor Wahid, sir, Professor, Department of Pathology, to enlighten us.
Good morning all, respected teachers and senior retired faculty members, my most respected Professor Natu sir, whose legacy, what he has left, I am carrying forward, and lot of discussion on AI. So I would like to share one couplet to change the atmosphere. कि अपना ज़माना आप बनाते हैं अहले दिल, हम वो नहीं हैं जिसको ज़माना बना गया. So, to start this, I would like to pay my tribute to our HOD, Professor V.S. Singh sir, who has asked me to present before you whatever newer things chemical laboratory and clinical pathology laboratory have doing. So I will give a short presentation of 10 minutes, what we are and how we started our journey. And Natu sir is here. If I am wrong, please correct me, sir. The first automated analyzer was came, I think, in 2005 or 2003 in the chemical laboratory. Since then, we are working few of the tests on fully automated analyzers and few of the tests on manual methods those days, and how we have adopted the recent advances. So these are the faculty along with me, and under the able guidance of our HOD, we are looking after all the central laboratory like chemical laboratory, who is the founder, that is the daughter of the founder of chemical lab, Professor Rashmi Chaturvedi is still here. And I also pay tribute to Professor Abhay Kumar sir, who was the great visionary, great leader, who has founded the laboratory and concept of chemical pathology under the umbrella of pathology department. So these are the faculty who is working with me, with senior, junior, resident, round the clock. They are posted in the different clinical peripheral laboratories with and 10 number of laboratories we are doing, like chemical lab. These are the working hour. In the trauma lab, 24 hours into 7, 3 laboratory we are running. In QMH building, in Lari cardiology building, and in trauma center building. Another rural services also, PSC Sarojinagar, we are giving clinical pathology services. And there are different collection centers that are working at different locations. Now the concept of all tests under one profile, under one roof system. And these are the statics of the trauma laboratory. More than 1 lakh number of tests in 1 month we are doing. And OPD, this is the OPD load. This is the Queen Mary's Hospital lab workload. And Lari cardiology, clinical biochemistry, and immunoassay with the special markers we are doing. And quality is also very much essential. That is why we are doing the EQUAS program with CMC Vellore as well as BioRed. And we are daily routinely monitoring the LJ charts and internal as well as EQUA program we are doing. We have successfully completed 4 cycles of NABL ISO 15189 medical testing laboratories, and the 2024 and 26 accreditation certificate has been granted with various scopes and of clinical biochemistry and immunoassay. These are the upgraded and fully automated machines we have in the chemical laboratory, and new starts in the QMH and Lari cardiology lab. Now we have transformed in the laboratory automation and digitalization with the advancement of middleware software on the basis of advanced machine learning. And what is the workload? This is the number of workload, like more than 8,000 samples per day we receive in different central as well as in peripheral lab with different collection centers. These are the laboratories. And what were the challenges? Challenges from the clinician side, that the report is not coming timely, increased TAT, quality check was not routinely monitored when the work was manual, and rerun, many times rerun problem was there, data was not consolidated, and there were resource limit. There was always hue and cries. Like there are 2 months for integration with the new instrument, it is not still ready. Supervisor, when can I get last 2 month test count for glucose? How staff encounter difficulty in handling the complex cases. Means there are so many issues when there was no middleware software. And we have started the middleware adaptation since November 2023. Project was initiated, and in January 2024, 2 labs were under the middleware, and 7 disciplines with 12 instruments. And nowadays, in January 2025, after completion of 1 year, 5 labs along with 12 disciplines and 43 instruments have already been incorporated with middleware software. What are the benefits of these softwares? This software means there are central monitoring. From our desktop, we can see the real-time working of the laboratory, what is going on in the trauma lab, what is going on in the Larry cardiology lab, what is going on in the QMH lab, whether the machine quality control was run or not, whether proper retesting if required was done or not, how many tests was yet to be reported, how many tests is completed. So on the real-time basis, we can monitor, group and select analyzer by site, department and analyzer type, view operational status of any analyzer and automation system, quickly access work list for more detailed analysis, remotely see the actual system on screen, and we can zoom it. Sample management is also live TAT monitoring we can do. Like here, how many samples is to be validated, how many samples is blocked to analyze further, whether the slide to be made and to manual review is required, any repeat testing to be done. Like this here we can do on the system, and real basis we can analyze here, we can see here how many sample is already validated and completed. Instrument, the middleware software, what are the basic characteristics that we have incorporated in the software? That is the instrument flags, QC out, interference indices like lipemia, icterus and hemolysis, manual review triggered, result data, delta check, critical alert, any analytical consistency to be violated, that could be seen on the single window. In hematology also, we can do patient demographic comments, clinical data, numerical results, manual cell counts, and as well as the various graphs we could see. Quality control also to be monitored on the real-time basis, and if there is any outlier in the LJ chart, we easily assess and automatically corrected, and corrective action has to be taken on the real-time basis, and at whether the lab is working at anywhere in the location in the campus. And various West Guard rules have been applied. Not only this, we can see the patient previous history to see if the sample is coming day by day for liver function test, kidney function test. So we can assess what was the trend of the patients by looking after the moving average dashboard. And lab statistics we could see like this here, everything to be monitored on the real-time basis. These are the few things to show. And what was the outcomes? We have started at the 1 month, the turnaround time for the laboratory of various laboratory that is working what was previously 8 hours, but after adaptation of this middleware software, the turnaround time was reduced to 4 hours, and after completion of 1 year, the turnaround time is about 2.5 an hour, and rerun and all the things has like this, we can save the revenue also. So what is the peace of mind of this adaptation of this software and the automation? Cost saving, reduce rerun and quality control, states to track the continuous improvement, better staff management, saved man hours, better reagent management, streamlined process, rule-based trigger and auto rerun, and same day reporting. If we receive sample by 2 o'clock, we can give the report in the same day, evening by 4 o'clock. Patient satisfaction, one-time quality reports, same day testing and consultation, and skip off queue. Thus, the biggest part of our digital transformation is changing the way we think. And at this, since dignitaries are already there, I will stop here. And thank you. Thank you all.
Thank you, sir, for a wonderful session. As we commence the program further, I now request our respected dignitaries to please join us on the stage. Respected Pro Vice Chancellor, Professor Abhijit Kaur ma'am, Dean Academics, Professor Amita Jain ma'am, our guest for today, Professor Thuppil Venkatesh sir, Professor Manoj Jain sir, our head of the department, Professor U.S. Singh sir, and Professor Ajay Singh sir. Please join us on the stage. Our chief guest for the day, Honorable Shri Brijesh Pathak sir, and our Honorable Professor Sonia Nityanand ma'am, Vice Chancellor, could not join us today as they were preoccupied. Now I would like to request my fellow colleagues to kindly welcome our guest with an Ekal Pushp. Pro Vice Chancellor, Professor Abhijit Kaur ma'am. We welcome you, ma'am. Dean Academics, Professor Amita Jain ma'am. Professor Manoj Jain sir. Dr. P.K. Agarwal ma'am. Professor Thuppil Venkatesh sir. Professor U.S. Singh sir. And Professor Ajay Singh sir. I would also request my colleagues to welcome our retired teachers and eminent guests whose consistent presence is a testament of their support. Professor Rashmi Chaturvedi ma'am. Dr. S.M. Natu sir. Dr. Anita Mehrotra ma'am. Ma'am is a wife of Professor Raj Mehrotra sir. We are very glad to welcome you, ma'am. Dr. Arun Chaturvedi sir. And Dr. P.K. Gupta sir. Thank you all for joining us today. Let us now invoke the blessings of the divine by requesting our dignitaries for lightening the lamp, accompanied by a Saraswati Vandana. या कुंदेन्दु तुषार हार धवला या शुभ्र वस्त्रावृता या वीणा वरदंड मंडित करा या श्वेत पद्मासना या ब्रह्माच्युत शंकरप्त वृतिभे देवै सदा वंदिता सा मां पातु सरस्वती भगवती निःशेष जाड्यापहा. As we commence the program further, I now kindly invite our respected head of the department, Professor U.S. Singh sir, to present the annual report showcasing the achievements and milestones of our department over the past 1 year.
ये नहीं है, ये absent है, ठीक है.
It is a great day for all of us. Foundation Day, annual Foundation Day function, that too 113th, more than a century old, most prestigious department of pathology. There are tales and stories of the hierarchy and reaching to the pinnacle of the academics by all the revered teachers. On this occasion, I would like to thank Honorable Deputy Chief Minister, Sri Brijesh Pathak ji, who has sent his message, which is there in the newsletter. He was about to come, but as you know, the assignments which are given to them are so much that somehow he is not in the Lucknow and he could not attend, although he had promised that if I am in Lucknow, I will definitely come. I remember with reverence and also welcome Professor Sonia Nityanand ji. And it is a very happy moment to again celebrate the most coveted award which has been given to him by the Government of India, the Padam Shri, which is the honor to herself, to the family, to the KGMU family, to the women, to the everyone. And the great thing about this is that his father, our teachers of teachers, Professor Nityanand, who was director of CDRI, and a very noble man I met him several times. And he was a person who will keep on blessing you until unless you are settled. So that is the legacy which he carries. And her father also got this most coveted award, Padam Shri from Government of India. It is one of the rarest of the rarest blessing, I will say, to the family, to Lucknow, to CDRI, to KGMU. We feel proud of them all. Madam, today, all of suddenly again I said, had some very important government assignment till yesterday. She was willing to come, but today she is busy with very important government assignments and thus could not come. But we are thankful for her message, which is there in the newsletter. I welcome our Dean Faculty, Medical Academics, Dean of Academics, Professor Amita Jain. We welcome Professor Abhijit Kaur, Pro Vice Chancellor of our university. We welcome teachers of teacher. No introduction is needed. Professor P.K. Agarwal ma'am, who has been instrumental in inspiring us all to do the best out of you. I welcome Professor T. Venkatesh, Director, who has come for this oration, today's oration. And it is really very inspiring to see a person at nearing 80 age, taking 4-day classes continuously for 5 to 6 days. And all the senior residents, junior residents, and whatsoever registered candidates were there, they were, they are bound with this charismatic teaching skill and the message which he was given. We are very much thankful to you, sir, for coming to our institution. And we will keep on, and we will seek your blessing throughout our career. So anywhere you are, Professor Wahid Ali Sahab will coordinate, and please give us your blessings. Professor A.K. Singh, I'm a very senior faculty in the Department of Pathology. Today, the day cannot be celebrated until unless we give reverence and gratitude to the root. And the root is our most revered teachers. Since the inception of this prestigious college, their contribution is immense. And what we are doing is just that legacy which we got, golden legacy which we have got, we are just making it forward. We are keeping it up. At times we go very down, then again try to keep it up. But no words to express my gratitude to each and every one of them for the discipline, for the teaching, for everything they did for the department and for the society. It is a matter of great pride that today we have to release 3 important things. One is the book, which has been Pathology Concise Practical Manual book. It was long pending, and this has been printed and edited by Professor Suresh Babu, who is again a very senior faculty, and Professor Preeti Agarwal. The second is the newsletter we have to release today, and we are very happy that we have made a KGMU Pathology Department Welfare Society, which is a registered society with all the faculty as its constituents, head of the departments as its president, and the rest of the post rotatory among them for in 3 years. All the students, including the undergraduate, postgraduate alumni, are their members just by paying a membership fees of 500 rupees. And we have developed a portal, www.kgmupdws.organization, and you can see this on the Google. It is a treasure because gradually we will write about ourselves, our achievement, and it will be reflected and seen throughout the world. The mission and the vision of our department or the pathology is, if you see the pathology, if there is a case, with either it is the outdoor patient or the inpatient, any disease, until unless we do pathology, diagnosis cannot be held. You can say that the hemoglobin is good, but the thing is we need a written report. So that way the diagnosis is done by ourselves, all the patients, to one and all patients. The second is treatment is based on that. The third is the medicines are given accordingly, and we see in the follow-up, and the prognosis can be predicted. And likewise, we can do a large number of the research and can derive better diagnosis, better treatment, better life. So in the mission, we would like to be the leader in this arena, and we want to relook at our work, self-reflect our data, and do innovative work, that what the data says and how better we can do. About this thing, if you see the mission is only threefold. All our department mission is student-centric. We want a student to give them independence, to give them self-pride, to them, give the opportunities of the self-learning, and above all, to be a very good person. And not only that, but also to be very critical. What is written in the book is not important. How, in what perspective, and what is their perspective, how to understand and better understand is our sole goal. And we give you full freedom. So our department is student-centric, very much friendly to all, either it is undergraduate, postgraduate, super specialist and all that. The second is any patient coming to our department is a godlike. We don't consider anyone as privileged or non-privileged. Anyone who is having an ailment is poor in our taxonomy, because economical is not important. If a person is not having good health, what next he is going to do? So we take care of each and every identified or unidentified anonymous patients in whatsoever the best capacity we have. The third is that we produce educational resources. Like I've said, the book is released. Likewise, we always interact and do that. And along with that, the research. What you have done, how can you better compile and interpret and do the things? If you see at our department, all the undergraduate courses, as mentioned here, is taught by pathology department. So it is BDS, MDS, you name any subject which is going on, all they are being taught in pathology. Then we have up to the super specialty level. Then we have PDCC programs under different headings. You all can see and appreciate. Likewise, value-added course of MD Pathology, Introduction to the Basic of AI. It is I will say the brainchild and the concept of Dr. Salini Bhalla, and she has worked, and it is very much approved by the EC, and it is currently going on. We have not only that, we believe that together we can do better. So we have collaborations with our junior, less privileged institutions, likewise the high privileged institutions. And if you see the name SGPGI, Balrampur Hospital, IRA Hospital, anyone, anywhere, maybe the IITs and all that, we do collaborate. We always dream, we don't remain static, we are vibrant, and we always dream that what has happened, we will go further. And we are trying to we have established oncopathology unit, and our dream is to get oncopathology DM seat. So that is a very lengthy procedure, and all the requirements of the NMC is being fulfilled. And I think within few years, we will have this very, important DM in oncopathology seat. We had a Board of Studies meeting, and few of my fellow colleagues, they gave me application, like Dr. Wahid has given PDCC in pathology and laboratory medicine, exclusively of pathology. It has nothing to do with microbiology, nothing to do with the biochemistry. All the training will be done in our setup only. So we don't need to take any type of no objection from microbiology or biochemistry. The second is the PDCC in artificial intelligence and advanced chemical and clinical pathology. Now, artificial intelligence, we all know, the science and the technology is a good servant, but a bad master. So if we use the AI judiciously, we are going to win, because we are giving services to the masses. Likewise, the PDCC in AI in hematology is requested by Professor Rashmi Kushwaha, so we will process and let it go to the, different forum and get it, approved. This is the status of our department. There are 22 seats of the faculty, 19 are full, 3 are still not there. 2 persons, in the main list, they did not join. Waiting list is there. I don't know what is going to happen. But anyhow, the 3 vacancies still are there. In the junior residents, now onwards, each year we have 20, and all the seats are filled up. In senior residents, we have 32. Likewise, the technicians are, sanctioned posts are 51, 31 is working, and there is a large gap. 20 persons are not there. They are retired, and we are very short of the staff. In lab attendant, again, the 33 posts are there, 13 are only there. 20 seats are vacant. So you can see that more than half of the department is vacant, because there has not been any recruitment of the technical staff since, I think, 2011 or 12. This should happen each year. In contractual, if you see the figures, again, it is very low, and we need more and more, because we run many laboratories, not only in the department, but many laboratories. As you know, that we have applied to increase the seat of MD pathology, because we have resources, and we can tackle with the all the MD students. So we have dreamed, or we have proposed to increase it to 30. And I am thankful to Dean Ma'am, I am thankful to Professor, the Pro Vice Chancellor Madam, and thankful to Vice Chancellor Madam to agree with this, and they have sent it to NMC for the inspection. So if we pass out this inspection, we will have further increase in the seat of the MD. This is about the regular and contractual requirements which are seen, and this much of the vacancies should not be lying vacant, because it does affect the working, and that to 24/7 throughout the year. If you see the structure of our department, we all know that what are the different labs. We have histopathology, cytopathology, different other laboratories as given here. We have peripheral lab, or you can take it as the satellite lab, because our mission is that doorside, bedside, sample collection and report delivery should be there. So that way we, in all the important departments, like where the life-threatening conditions are there, like cardiology, like in trauma center, like in gynae, neonatology, like in medicine, likewise in the OPD, and several others as mentioned, we have centers, and these centers are doing the work of the clinical pathology and applied biochemistry or chemical pathology 24/7, and all these labs, we are very proud of, they are all NABL accredited. And more, it is a matter of pride that there is not even a single paper publication of KGMU in which the work or the data from these labs have not been incorporated. We are behind the curtain, maybe that our names are there or not, but the fact remains that all the patient's diagnosis is done by our simple pathological test. The data is NABL accredited, and high impact journals, they do acknowledge this and publish. These are few of the services which are specialized services, like now the ISC, molecular techniques, FISH, basically the DNA, RNA, or you can say the different type of the targeted therapy-based diagnostic facilities. They all are a reality now and being done and being we are very much thankful to all the patients and all the clinicians and the surgeons that they do believe in us, and we are progressing. All the labs, if you see, they are, especially the chemical pathology, they are all NABL labs. And we are using a lot of this information technology. So they are connected with LIS, with HIS. We need a robust data center in KGMU, like the PGI, like the RMLMS, or All India Institute of Sciences, so that our diagnosis is not based on slide and this and that, or only the serum or the plasma. It is based basically about, because our teacher said that you are firstly a doctor, you are a clinician, you are the, clinician of clinician, because you know at molecular level what is going wrong. So we need that what really went wrong, what is the age, what happened, what is the treatment given, what are the tests given. So the patient's requisition come, then they go for retrieval of all this, takes time. And what our concern is that TAT should be instantaneous as much as possible. So if the data center becomes robust, which is not at all at the moment, because we should just click a UHID and all the data should be there. We need not to ask anyone, and anything you have done must come in the data itself, and it should be reflected. So that, I think, is an area which is deficient in our setup also in pathology. It is only in the chemical pathology, but we are not doing exactly the same in the rest of our specialty, and a lot of work is needed to be done. Now, these are the few of the infrastructure. These slides have been taken, like these two slides, because we were given with the latest of the gadgets in chemical pathology or biochemistry, and they are all high-end machines, and likewise in the coagulation and hematology. If you remember all the critical cases, case of the, unconscious patient which comes, the parameters become the patient. And it is very important that we have the best of the machine to give the highly accurate results. So we have got 4 high-end machine, like for the HPLC or the autoanalyzer or the coagulopathy and different others. And they have added value to our whatever the research report we give. And we are very fortunate that we can see the live pathology. Like we are giving something, diagnosis made, treatment given, again we are seeing prognosis, we are seeing, and it has become for decades altogether. And to our surprise, and also it is a very happy note, that cancer patients are getting completely cured. We know breast cancers for last 20-25 years, cured, ALL cured, AML cured, renal cell carcinoma cured, and we know by name the patients, they have become friends to us, the family has become friends to us. So that is a great thing, which has become because of the better diagnosis and treatment. Now, these are the few of the things which university has given, which we had not. Like the new gross station, the grossing room has been built in our department. It was a requirement. The lift was not there, so up to 2, it was really difficult because a few of us were physically challenged, and otherwise also all the patients, especially the leukemia and all that, they had a lot of problems, especially with the 2 gram of the hemoglobin, to go stair up and get their test done. So we are thankful to Professor Nityanand ma'am for giving us the funds and also making it a reality. And likewise in audio, in the teaching, welcome sir. Professor Rajendra Kumar sir is the ex-head of the Department of Respiratory Medicine. Big personality. Welcome, sir. So, in the teaching, we have got the audio-visual gadgets. Likewise, we have got different microscope like the DECA and the Penta, by which we discuss the cases, diagnose the cases, and we do the CMAs, conferences, this and that. Now, this is the sample load which we can see. It will be difficult to, go through to each one of them, But I can say that in the trauma center, if you look at the figures, it is exceeding 13 lakhs per year. I'm talking about a patient. 13 lakhs samples means for us the 13 lakhs patients have been investigation. And one in Parsha, one prescription may have 20, 30, 40, same day, again the same number of the cases. So only we have counted the patient, not the number of the tests, which will go in crores and crores of this thing. And all our data, we are very proud of this, that we don't need to send our sample to anywhere else. Our data is authenticated. We can see the live biochemistry going on and whatsoever. In histopathology, doing 23,000, more than 23,000 samples, it is not a joke. And then, I will say that it is a proud thing that people are relying so much in our diagnostic services. Likewise, we can see for the other tests as well. And out of this, I will say that the 30,683 cases in bone marrow biopsy, lymphoma FNSE, throughout the year, they are all live patients, diagnosed, treated, follow-up, all the data we have and we are doing, and we are proud of it, that people are doing it. And as I have said, the resources always, and the space, they become less. But still we are taking care of everyone, and it is parallel. Our reports are parallel to Tata Memorial, to internal or the external aquas. We are winning everywhere, or we are awarded better marks there. On the requisition, we start any new test when the clinical site people, they require. So they ask for these tests. We see the logistics, whether it will be done or not. We are very much thankful to the hospital board for giving a very extended, subsidized rates for all these tests. Suppose some test is done outside 1,000, we are doing just in 200, 300 rupees. Very subsidized. And out of all that, 50% of the tests are free, because all the patients, they are covered under the government benevolent schemes like the Ayushman, this and that. So these are the few of the tests which has been aided. Out of that, the ACTS, you can go through to it and things likewise. They are very important, relevant tests. It is not that we have started it. They were asked for and we did it. This is a very busy slide. You can see all the faculties' names are there. And these are all the assignments which we are doing. We are very proud of our faculty that they take care of the works related to the pathology. Likewise, in all the academic activity of the university, they are participating. And few of us are the faculty in charge of different departments, like faculty in charge of the IT is Dr. Preeti Agarwal, faculty in charge of the sports is Dr. Rashmi Kuswaha. Many of the wardens and assistant warden is from our place. Likewise, in the dean, sub-dean, Dr. Reddy, and in the quality, Dr. Shalini. And you can go through to, Dr. Madhu Kumar, all the names, Dr. Wahid Ali itself, not only this, but he is taking care of many, many other functions in our department. And likewise, not only here, but outside also, because Dr. Wahid has gone so many times to Rajasthan, especially they were impressed with the system which we are doing here, and that too affordable. Even the SGPGI people are very much impressed with this system delivery and all that. So several times he has gone on part of the UP government to let them know and implement so that they can also do better pathology diagnostic services. Now, these are again you can see the name of Dr. Simanjali, Sumaira Reddy, Dr. Shalini Verma, Geeta Yadav, Mala Sagar, Preeti Agarwal, Dr. Chanchal Rana. One and all faculties. So they are doing work not only here, but there is no work in the KGMU where our representation is not there. And it starts with the foundation day function of the KGMU, and
keeps on happening throughout the year. So largely the Foundation Day function is done by our residents and Dr. Shalini, few of Dr. Sivanjali, few of our faculty. And it is coming for, many, many decades. Now, these are the invited. Participation and invitation is a slightly different. So our faculty are invited in national, international, provincial, CME and conferences. And we are very proud of Dr. Rashmi Kushwaha, Professor Atin Sengai, who could not join here because of the accident, and Dr. Chanchal Rana, who has been invited at different forum. They are all the national level forum or maybe international level to give their this lecture, guest lecture, which is itself an honor to themselves, to the department, to KGMU. Now, again, it is a very busy slide. You can see the names of everyone. I have reiterated. They are participating into activities. And this is the university responsibilities being done by Rashmi as said president of the Athlete Association. Atil Sengai is Assistant Dean, Paramedical and in charge, Linen. Redhi Jaiswal, Assistant COE Examination in charge, Furniture Sales. Of course, she will give furniture to us. I request her. We need chairs. We need chairs. Member Ethics and Research Committee, Professor Wahid Ali, Nodal Officer, UED, Department of Pathology, Executive Council, Committee Member, NABH, which is an honor. Now, these are the university responsibilities which has been given to Dr. Preeti Agrawal, who is in charge of the IT cell, faculty in charge. It is a very, very, very tough job, I will say, because it is still in a very primitive stage and very, very hard work and very demanding. Then Dr. Sumaira Qayyum, Member Secretary, LBC, and likewise you can go through to the full chart. Dr. Salini Valla is faculty in medical education. Again, you can read. And Dr. Geeta is Executive Committee member, DHR, MEU, Member Equipment Cell, and all that. You can go the details about her. Now, these are few of the events which were done last year, like we celebrated the annual Foundation Day. Then we had CME in February, in April again, May, and May. So we have enough number of the CME conferences which are done exclusively by our department with the collaboration of the other departments on important topics relevant for junior residents, for teaching, for the patients and everyone. Now, these are few of the CME organized, like you can see Dr. Wahid giving lecture on the cardiac and the traumatic brain injury. And this is the Thalassemia Day being, and Dr. Rashmi Kushwaha is organizing this. Then ovarian cancer by Dr. Redhi Jaiswal, she did it. And again, the diabetes and cancer, it was done in our department. And this Dharma Pathology Conference was, or CME was organized by Dr. Atin Sengai. As I said, he is medically not fit to come. The faculty in charge, the achievement you can see, and Dr. Rashmi Kushwaha, Professor Rashmi Kushwaha got this fellowship of the Indian College of Hematology. And then Dr. Atin Sengai got the Appreciation Award. Then Dr. Wahid Ali was invited speaker, and that's the important thing, invited speaker in European Atherosclerosis Society because his work relates to atherosclerosis and he is a big name in atherosclerosis research. Dr. Redhi Jaiswal got the Eminence in Research Award 2014 Research Showcase. Dr. Chanchal Rana got a very coveted award, Dr. V.R. Khanolkar Award by the Indian Association of Pathologists and Microbiologists for her groundbreaking research on the impact of the thyroid cancer reclassification in Indian patients. So our faculty not only is working, but they are getting in national conferences awards, and that too of the relevance in that there will be inputs as far as in the classification of the disorder is needed. Dr. Sumaira Qayyum, she went overseas and participated in US CAP 2024 annual meeting in March 2024 in Baltimore, Maryland, USA. Dr. Salini Valla invited guest faculty in ISH WCON by Indian Society of the Hospital Waste Management. Dr. Shalini Valla is also doing a lot of work in quality, likewise in the teaching and in the waste management and foundation day and things likewise. Dr. Sivanjali Raghuvanshi invited guest lecturer in the Institute of Medical Sciences on the cervical cancer. Dr. Geeta Yadav got the Eminence in Research Award 2024, which is a huge achievement. These are the publications, total 85 in national, international journals. They are all high-index journals, PubMed journals, in which the department during this last 1 year has done. Now, this is the few of the things which has been done. Book, as I have mentioned. The second book, earlier book was Laboratory Manual of Laboratory and Technician Training, and it was under and co-authored by Professor Suresh Babu, Rashmi Kushwaha, Mala Sagar, and Dr. Madhu Kumar. Book chapters were written by Dr. Rashmi Kushwaha. Again, our book chapter was written by her. The details are mentioned. These are the research projects. Dr. Millie Jain got a very, coveted, I will say, the DST, this research for thalassemia patients, and she is going to start the work because machines have started coming, and in a short while, in a few weeks, the work will start. It will be about the thalassemia, its prevention, antenatal care, and things likewise. And we can see the principal investigator's name, Dr. Geeta, is again a principal investigator. You can see the granted research project. And likewise, the principal investigator is Dr. Rashmi Kushwaha. Again, Dr. Preeti Agrawal, examination of the microRNA 155 in breast cancers. And Dr. Madhu Kumar was appointed as a mentor. Dr. Atin Singh is the principal investigator. So what I'm trying is that we are getting mural, intramural, extramural, coveted, important government-funded schemes to work in research, which will be basically for our growth and survival. Number of the pieces and all that, there were 14 PGA students, and 2 completed PhD during the last year. And these are the awards given to our bright residents. And Dr. Kranchi Agrawal, Dr. Harshi Srivastava, Dr. Harshita, they all got first prize in different presentations, maybe the oral presentation or the poster presentations and things likewise. Extension and all that, we are also doing a lot of social outreach programs. So all the camps organized ourselves or with the collaboration of the other departments who are doing that. And under this heading, if you see Professor Suresh Babu, Professor Rashmi, all the faculty department of this thing, our pathology, Dr. Rashmi again, and Dr. Atin and Wahid, they have been doing this camps, and this will be basically for the prevention, diagnosis, and awareness of the disorder. Because in ovarian or cervical or the HIV, this human papilloma virus, and there are several, even for the anemia and all that, awareness prevention is important. So we are going to the grass root level. We are going to the people to collect the sample to make them aware as a benevolent work. Now, this is about our department. You can see the histopathology. The residents are working very hard. I don't know they are understanding or not what they are doing. So, again, this is the grossing room. And this grossing room, enhancement, a new grossing room has come, and it is much better. And it is what it should have been. So we are blessed with that. We are very much thankful to Professor Sonyanand ma'am for granting funds. Then this is the tissue process histopathology lab. You can see the FNSC room here, liquid-based cytology. We are constantly doing this liquid-based cytology of all the patients coming from the gynae on a very subsidized rates. And of course, the patients who are covered under the free schemes, they are all free. Then this is the immunohistocytochemistry lab. We are doing ISC. A large number of the panel their molecular laboratory in which we are doing the PCR and all that. And then we have, as already said, that clinical pathology is having hormone division automated analyzers, which is again a very precision gadgets. The second one also is from the chemical pathology. And this is the electron microscope, which is very, it is under Dr. Atin, and we are getting renal pathology, dermatopathology, different other specimens, and doing for research for the diagnosis, the electron microscopy. And this is the analyzer, hematology or hematopathology work is going on, coagulation laboratory. Then we have the lymphoma leukemia lab. Lymphoma leukemia lab is a national registry lab. It is a very old lab and very prestigious. Again, you can see the leukemia and lymphoma lab. Neuropathology lab, it is a division unit of the histopathology. Dr. Atin and Dr. Suresh is there. We have organized, as you see, few of the photographs are for CME organized. You can see the media coverage which is going on. And this is the, you can see the roses and the thorns. So both the people are there. And it is one has to take. Thank you. Thank you.
Thank you, sir, for the display of our department's glory. Now, I would like to request our dignitaries to kindly come forward for the felicitation ceremony. Our dignitaries are requested to come forward, please. We would like to felicitate first our guest orator for the day, we would start by felicitating our guest orator for the day, Professor Thuppil Venkatesh, sir. Sir, we are very humbled and glad to have you here. Next, we would like to felicitate our guest speaker for the day, Professor Manoj Jain, sir. We need a huge round of applause for sir. In continuation, I would like to request our guests to felicitate our retired employees to acknowledge their selfless devotion to the department. I would like to invite Shri Ram Bahadur Maurya ji, Shri Pradeep Kumar Verma ji, he will be retired this year, Shri Pradeep Kumar Verma ji. Shri Saten Kumar Shukla ji, I kindly invite you. Our department always recognizes the hard work of us residents, in continuation to which I would like to invite the final year residents, starting with Dr. Shivangi Nayak. Dr. Shivangi Nayak. Dr. Harshpreet Kaur. Dr. Mantasha Mukhtar,
Dr. Tanya Suryavanshi, Dr. Diksha Chaurasia, Dr. Ashi Singhal, Dr. Anjali Gautam, Dr. Shashi Nandini, Dr. Sutirth Vajpayee, Dr. Soumya Agarwal, Dr. Radhika Singh, Dr. Vidya Rashmi, Dr. Sana Parveen, Dr. Amit Kumar Verma, Dr. Arina Alam, Dr. Harshi Srivastav, As we move forward, I would request our esteemed dignitaries to release our annual newsletter of Department of Pathology. Please give it a round of applause. We are very glad to inform you that our department, under the guidance of respected Professor Suresh Babu sir and Professor Preeti Agarwal ma'am, has created the book Pathology Concise Practical Manual. I would request our dignitaries to release the book. We are also extremely proud to have launched the KGMU Department of Pathology Welfare Society, which aims to reconnect its alumni and impart knowledge to budding pathologists.
We are thrilled to announce that Dr. P.K. Gupta sir is presenting a check to the Alumni Association, KGMU. Dr. P.K. Gupta sir is a Georgian of 1981 batch. Sir is currently the director of PK Pathology. We are humbled to announce that sir is donating 50,000 rupees check to the Georgian Alumni Association. The check will be received by Dr. Sudhir Singh sir. An award has also been declared in KGMU in the memory of Dr. Meera Rastogi, MD Pathology 1990 batch from KGMU. This award was given for the first time to the MBBS student securing highest marks in first, second and third prof this year. In continuation, we would like to felicitate our guest, our Pro Vice Chancellor, Professor Abhijit Kaur ma'am. Thank you, ma'am, for joining us today. We would also like to honor our Dean Academics, Professor Amita Jain, ma'am. Our head of the department, Professor U.S. Singh, sir. I would request the dignitaries to kindly join us back.
I'm so thankful to Dr. U.S. Singh and the whole faculty to invite me to attend this function. And I feel so proud to see this department going so high and doing so much academic work. You know, I joined the department in 1966 as a demonstrator. At that time, the department was pathology and microbiology. And from that day, 1966, today it has gone so many specialties, super specialties, and faculties writing books. Yeah, and this marathon race, Rashmi Kushwa, one-day marathon race. My goodness, itna expertise, very good. I feel so proud to be a retired teacher of this medical college, of this pathology department, and I'm thankful to my teacher, my mentor, Professor Arvind Mehrotra and Professor Taimwal. Because of them, I'm here today, and I feel so proud. I thank you so much for everything, and I give you with so many blessings, long life, healthy life, active life. Keep on doing all this. God bless you all. Thank you very much. फंक्शन हुआ है।
Now, I would like to call Dr. Venkatesh Thuppil sir to address the audience with few words.
We are in a great institution. We are with great people. We are part of great tradition. The institution which started, though in 1911, was officially launched in 1912, January. I think this January is the right time to remember that January also. I do not know how to address you. Honorable Vice Chancellor or dignitaries or staff, students, I get little confused. I would like to address all of you with only one word. Before that, I would like to ask you one question. Give me a very truthful answer. Is there anybody, by raising hand, okay, is there anybody here who never took any medicines in the past? Raise your hand. I know no hand will go up. Is there anybody here who will not take any medicines in the future as long as you are alive? Raise your hand. I know no hand will go up. Therefore, how should I address all of you, including myself? My dear patients, we are all, why I am telling you, the moment we think we were patients, we are going to become patients, or we are patients, our respect towards patients will go up. WHO last year said, my right is my health, or my health is my right. I little differed. I wrote to them as a guideline development committee. My right is not just my health. My right is my environmental health. If environment is polluted, my health is gone. My right is my animal health. My right is my agricultural health. If pesticide, insecticides are used too much, then where is my health? I am extremely happy to be in this institution. I have come number of times. I feel I am part of this institution. I tell you, this institution has unique. This is an institution where it's like a chair on which you are sitting. The chair has 4 legs. What are these 4 legs of this institution? One leg is the leg of teaching, learning. Teaching, learning. No chair can sustain with only one activity, teaching and learning. This institution also has leg of research. Any chair with only 2 legs, you cannot sit on that. You will fall. There is a 3rd leg on which you are sitting, the chair of this institution. The 3rd leg is leg of service. The commitment. The service is so much. Can we sit on the chair with only 3 legs? Learning, teaching, research, development, and service. We need one more. That every one of you, every one of us, we need the 4th leg to make that chair sustainable, that institution sustainable. That chair, that leg of the 4th chair, you know which one? Your commitment, your passion. We saw our HOD. I tell you, your commitment and passion in your talk, commitment and passion, I saw with Professor White. I tell you, commitment and passion in every one of you attended the 4-day course which was boring. You tolerated me. I tell you, that commitment and passion, madam, for Honorable Vice Chancellor, is the greatest asset of this institution. And I'm sure the youngster sitting at the back, you please carry on this. We need your commitment, you need your passion to make this institution more stable, more sustainable. All the best to all of you. Thank you.
Thank you, sir, for inspiring words. It's now time to hear from our dignitaries whose vision and words inspire us. I would like to call upon Professor Amita Jain, ma'am, Dean Academics, to enlighten us with her wisdom.
Good afternoon. Thank you, Dr. U.S. Singh, for bringing me here. It's like homecoming for me. Every time I come here, I feel like I'm a very deep part of this department. This is where I did my MD from long time ago, but since we are next to each other, physically located also, I feel like I'm very much part of it. Dr. Venkatesh, thank you, sir, for teaching me how the laboratory accreditation should go. And I think we have never disappointed you. I must tell you that we are an NABL accredited lab since then. And not only I have heard you few times as lead man of India, but you are also the laboratory quality assurance man of India. So thank you for teaching us. Lot of my teachers, my friends, my mentors, I'm seeing in the audience. And I'll start with Dr. P.K. Agarwal, madam, who has taught me not only the pathology, but also how to conduct yourself in the department, how to behave. Lot of things she has taught, and it's a very long list. I'll not bore you by saying that. But thank you, madam, for being part of my life. Dr. Natu, my teacher, Dr. Madhumati Goel, not only my teacher, my mentor, my friend, and actually my stress buster at times. I'll say like my anger pillow to whom I could go anytime and say whatever I wanted to say. Thank you, ma'am, for being part of my life. Dr. Rashmi, Dr. Anita ji, PK, Gupta Saab, Manoj, and all the faculty members of pathology department. So they all very much part of my life. Sanjay is my batchmate and very good friend. We did MD together. Thank you, Sanjay. Professor Rajan Prasad, Dr. Arun Chaturvedi. I see it's a lot of faculty who are from KGMU. So good morning to you all. The staff of Department of Pathology, residents, students. It's a very, very rich department with very rich legacy and bright future. We have seen a good, illustrious report presented by Dr. U.S. Singh, and it speaks volume how the department functions, and a lot of good things have happened, but two things which I am very, very impressed with is the manual for pathology. I think there used to be a manual which we all had studied, and that's around 35, 40 years ago, so it was really needed. Thank you for bringing it out. I'll not waste any time, and since I know we are running out of time, I congratulate you, your whole faculty, staff, and all the students, and I wish a very bright future for the department. Thank you very
much. Thank you, ma'am, for your kind words. Now, I would like to invite Professor Abjeet Kaur, ma'am, Pro Vice Chancellor, to share her thoughts with us.
Good afternoon. At the outset, I bring you greetings on behalf of the Honorable Vice Chancellor. She's busy, so she's not here. Actually, it's a very humbling moment. I have my teachers here in the hall and on the dais. You know, when you are a kid, your parents, your elders teach you how to walk, teach you how to talk, how to sit, how to support, and how to work. I have been privileged, singularly privileged, in having been taught by such stalwarts. So many of them are sitting here. My salute, sir and ma'am, to each one of you. I totally agree with Dr. U.S. Singh that the Department of Pathology is an integral part of patient care. At every level, we as clinicians, I'm a surgeon, so I know that right from the pre-operative preparation to my histopathology, I bank upon them. And we are all very privileged to have such a wonderful, committed, academically progressive department in our college. And it's not just that this department is academically inclined. I'm not going to stand here naming people, but our university administration is deeply supported by the members of this department. Thank you all, each one of you, for taking up the roles in addition to that excessive work that you do. And without wasting much time, I must commit that my excitement for the lecture that you are going to deliver today is something which was built yesterday by Professor Madhumati Goyal. She said to me, you have to listen to that lecture. And I have no doubt in my mind that if a person of her stature is saying this, the person who will be delivering, it would be like the sun. Thank you for having me here, and many congratulations on this day, and wish you a bright future. Thank you.
We would also like to welcome Dr. Madhumati Goyal ma'am, in charge, Lab Medicine Medanta. Dr. Sanjay, HOD, Hind Sitapur. Dr. Rajendra Prasad, ex-HOD, Pulmonary Medicine, KGMU, ex-Director, Patel Chest Institute, New Delhi. Let us now proceed for a group photograph capturing the essence of this memorable day. Next up, we have a very special Foundation Day oration on lead-free or lead-safe for One Health by Professor Venkatesh Thuppal sir. Sir is the director of Foundation for Quality India. It's very hard to concise sir's achievement in few words. Sir is an advisor of Association of Healthcare Providers of India. He served as the principal of Advisor of Quality Council of India. Sir has been serving NABL as lead assessor for over 15 years. He has almost published over 350 scientific papers.
This is not important. Talk is important. Pranams to you, madam. Pranams to you. With the permission from Honorable Vice Chancellor let me take the freedom of sharing a little bit of what I have learned. I would like to remain as a student. I don't want to be a teacher. The reason is, teachers retire, students never retire. Always be a student. We know that number one environmental poison all over the world is lead. Nothing else, only lead. Whether you go to Japan, US, whether you go to some unknown island, you still have lead. Even in Andaman Nicobar tribals, I collected the blood samples of tribals, found lead in that. It is sarvantaryami. Everywhere it is there. It is toxic. We are the culprits. During industrialization, we took the lead out of the earth's crust and then started spreading all around. You know how much of lead we have thrown around? Every year more than 8,000 metric tons of lead is going into environment in India. Forget about the other parts of the world. Now the question is, all over the world, big organizations like WHO, UNICEF, UNIDO, they are all looking at lead-free world. I totally differ from them. You can never have lead-free world. You will always have lead around you. But for lead, my voice would not have reached you. But for lead, UPS would not have worked. You have to have lead around you. That is safe as long as they don't get into your system. They don't contaminate the environment. Therefore, should we go for lead-free or lead-safe? Answer is, you know the answer. We cannot have lead-free environment, lead-free world where we live. We can at least have lead-safe environment. I told you about one world and one health. We have only one world, one life. That life depends upon environmental health, animal health, agricultural health. If they are not healthy, we are not healthy. Therefore, we need to biomonitor toxic substances around us. NCDC invited me to deliver a talk on solving this problem. They said, how much time you need, sir? I said, I need only 5 minutes to solve this problem. Global problem, national problem of toxic substances around us, whether it's a pesticide, insecticide, fungicide, herbicide, whether it is lead, cadmium, mercury, arsenic. How to solve this problem? First, we need to get a data. Where can we get the data? If we have the data, I believe that every problem has a solution. If there is a problem which has no solution, it is not a problem at all. I said, we need to have centers across the country for the biomonitoring of toxic materials. I want KGMU to be one of the centers. I request our Honorable Vice Chancellor to kindly consider this. I will tell you how we can go about. I propose Project 797. What is this Project 797? Wonder number. I went to PMO's office. I had an appointment with Prime Minister. And he asked me, "Ye kya hai 797?" I said, there are 797 districts in our country. Every district hospital and couple of other hospitals can establish one room exclusively for biomonitoring of toxic substances in that district. In air, water, food, and soil, we get a 3D picture of how much of lead is there. If somebody is living in that area for 10 years, 5 years, we can even predict what is their blood lead level. If I ask you, is there anybody who knows your blood lead level here? Anybody here, do you know whether you have lead in the blood? Either say yes or no. You have lead in the blood. 53.5% children as on 1999 in 7 metros in India had their blood lead level about 10 micrograms per deciliter. As a result, their IQ was already reduced by 8 to 10 to 15 units. And as a result, when they become human productivity, they have already become human productivity, they were 12 years as on 2012, as on 1999, now they must be around, add that number of years. The human productivity got disturbed. That is, to do 4 hours work, they are taking 6 hours. As a result, there's a national economic damage to a tune of 600,000 crores, the budget of 2 Jharkhand states. This is the impact, economic impact of lead toxicity. Therefore, Project 797 will be launched very soon in this country, where every district hospital will have a separate unit with the existing staff. Space is there. They collect samples, send it to national laboratories to get lead, cadmium, mercury, pesticides. There were lead and you. You are having some lead in your blood, I don't know how much, and you don't know, you don't have any symptoms of lead toxicity. Therefore, the symptoms of lead poisoning is no symptoms, because many of them overlaps with other symptoms, like anemia, for example. Anemia may be due to many things. Therefore, past, present, and future of lead is past, present, and future of our lives. I do not want to spend much time on this One Health. You are all aware. Interconnectedness of human, animal, environmental health is One Health. We cannot live as an isolated humans. We have to live with the cattle stock. Largest One Health global study undertaken in India. Largest was the lead level estimation. I was the director of the project between 1990 and 1999 without single rupee from any of the sponsoring agency or in India or from any loan from any bank. What we did, we just measured the anemia amongst our 25,000 people. Wherever there was anemia which was not responding to folic acid and iron, we did blood lead level. This was supported by George Foundation, one Indian who was asked to retire, voluntarily retire. He was in Indian Army because his hearing was poor. Then he came to me. He said, "Professor, do you know how to measure my blood lead level? Because in Army they told me I have lead poisoning, lead toxicity." I said, "I don't know. I only teach that lead causes anemia." He said, "If I give you one instrument, will you measure?" "Why only you? I will measure in many people." He gave me 100 instruments. We measured in 23,000 people. That is the world biggest study, population study, which resulted in a shocking news. Governors were there, vice chancellors were there from many universities in Hotel Ashoka in Bangalore. I said, only with 2 slides, I'll show you one of the slides. More than 53% of children below 12 years, as of 1999, you were not born at that time, had their blood lead level above 10 microgram per deciliter. Then what to do? We were adding tetraethyl lead to our gasoline, petrol, as an anti-knock. I said, "Please don't add." "No, we have already purchased about 6,000 metric tons of tetraethyl lead with World Bank money." See, World Bank had given money to buy poison, to poison our own people. Our people had accepted. We went to World Bank. I took an appointment with the chair of the World Bank. He said, "What do you want?" I said, "One letter from you saying if developing countries do not introduce unleaded petrol, no more World Bank loan." He said, "Why are you telling me? We have given loan to India to buy tetraethyl lead to use as an anti-knock in petrol." Then I told him how our children are suffering, dying. He said, "What happened?" I said, "At the same time as I am talking to you today." My meeting with the World Bank chair was at the same time. Same time I was sitting in my department as professor and head of the department on one day. I saw a young couple with a baby walking in front of my chamber. I asked my secretary, "Who is that?" "Sir, they have come to see you." I said, "Please call them inside." I went outside and called them. They came. I observed they had no footwear in there, no chappals. Poor people, somewhere from Bihar or someplace. Couple with a female child, 3 months young female child. They gave me the slip. They had been to hospital. Some intern was checking them because child was getting the convulsions after convulsions. And he asked, "Kya kar rahe ho?" He said, "Private." Then he would have written just private and he would have kept quiet. That young doctor like you asked, "What private job?" He said, "I am breaking battery, taking out lead, making pipes for the toilets because it will not get corroded." Then he said, "Oh God, that may be the reason. Lead must have gone into your baby." Then he sent the child to us because lead has no blood-brain barrier. Lead has no placental barrier. This man was working with lead. I got married. In one shed, in one corner, he was making roti and his wife was making roti. He was breaking and melting and smelting lead. That lady became pregnant, inhaling all the lead. All the lead went into her fetus. From fetus brain, there is no barrier. And that child, when it was born, started getting convulsions. I looked at that small, cute female child. It was smiling at me, very fair. I took that child in my hand. I called my technician to come and do the heel prick and take. That facility is there in this institution. I'm very happy to tell you. This institution has that facility today. Now, when the heel was pricked, blood was collected in a capillary, technician took that blood for analysis. He asked, "Kitna time lagega, sir?" I said, 3 minutes. It's a NASA technology, anodic stripping voltmetry. When I was holding the baby, I'm waiting for the result, talking to this young couple. The baby got a very powerful convulsion. I don't know what happened. It became still. Something told me something has gone wrong. I called the nurse and pediatrician. They came and said, "Sorry, sir. The moment you say sorry to anybody, it's the most dangerous thing. If somebody has gone, you say sorry." Child was dead in my arm. The child which smiled at me. The child would have been sitting here today. The child was no more. I could not. The report came. How much lead? Only 69 microgram in 100 ml of blood. Imagine. You can't see milligram with your naked eye. It's microgram, 69 microgram. I could not keep the baby on the table nor give it to him. When the report came, he's asking me, "From now onwards, there is no problem for my child. My child will be all right." I said, "Yes, there is no problem to your child because child is not alive. It is dead. If child were to be alive, it would have been dependent on you for the rest of its life." He cried, his wife could not stand, she collapsed, and I could not control myself. Same time, I tell you. Somehow convinced him, told him that it's all God's will to protect, prevent any later on problem to family. Then I went home. I was in the quarters at St. John's. Went home for lunch. My wife served food on my plate. I was mixing rice with rasam. I could not eat. I could not take. It was impossible because my hand, same hand, I was holding that baby. And next, within 1 hour, how can I use this hand to eat food? She asked me what happened. I told her the entire story, how I lost one female child. She asked me one question. Even today, it's lingering in my mind. I'm asking you that question right now. Are you born to is that child born to its parents out of choice or by chance? Are you born to your parents out of choice or by chance? I tell you, what a question. Are you born to your parents out of choice or by chance? Nobody selected you. Your parents did not select you. By chance. That child would have been tears in his eyes. He said, "What do you want me to do?" I said, "Please give one line letter. If developing countries do not introduce unleaded petrol by March 2003, 3 years' time was given. No more World Bank loan." When I went to Parliament Secretary, requested to stop getting tetraethyl lead and used it, they wouldn't listen to me. But World Bank chair gave a letter. I typed the letter, brought that letter, gave it to all the developing countries. I tell you, one good thing in my life happened. On March 2000 itself, they did not wait for 3 years. All petrol bunks all over the country had a board, unleaded petrol, unleaded petrol, unleaded. One letter, I tell you, protected millions and millions of IQ of all of us in a developing country like that. Soon after that, you know who invited me? Islamabad invited me. I went there. They said, why don't you give a talk? We also would like to introduce this. I was there for 3 days, 3.5 days. I said, more than tetraethyl lead, your surma is causing problem with lead and antimony sulfide. There are hundreds of other sources. All this leads to one health only. We are one man, one life, one family, one globe, one health. Of course, I will, why one health matters. You know COVID-19, what happened? Affected the entire globe, prevents zoonotic diseases, addresses antimicrobial resistance. This year onwards up to 2030, World Health Organization has said only 2 things we have to do. Only 2. Hand hygiene and what else you know? One is hand hygiene. What is the other one? Find out. I'll give you time up to lunchtime. If you don't find, I'll tell you. This. Infection control. How do we control infection? By controlling indiscriminate usage of drugs, medicines, especially antibiotics. Antibiotic stewardship has come now. Of course, enhance environmental sustainability. I would like to see one day in this hall, the Vice Chancellors of Health Universities, Vice Chancellor of Agricultural Universities, veterinary universities together with the experts to discuss about One Health. It should happen very soon. Somewhere it should happen. Okay, it's a transdisciplinary approach. It is not just pathology, microbiology, biochemists getting together. It's not the Ayurveda, Unani, Siddha, Ayush and allopathy sitting together. It should be a global cooperation to protect your child, grandchild and great-grandchild for sustainable development. Okay? World population is growing and we have to face the big problem. It's a big data. Global lead burden, if you see, over 240 million people are overexposed to lead and over 99% of them are having more than 20 microgram per deciliter in developing countries. We saved one child in Lucknow. In this hospital, we saved one child by name Rishi. When it came here, we had a conference. Dr. Abbas was head of the biochemistry that time. The child was found having blood lead level of 200 microgram per deciliter. Everybody was shocked. How this child is alive. The father brought the child as if he was on his shoulder. It was like a turkey towel on his shoulder. And Dr. S.J.S. Flora here got the desmarcaptosuccinic acid as a chelator. The child is alive today. Child is doing his internship or something it is doing. We can save 100% preventable. You know, 853,000 deaths are there annually because of lead alone, lead toxicity. And 90% of cardiac problems are associated with lead. Indian lead burden is not different. Adults are also affected by lead toxicity. Whenever I meet people, elderly people, I keep looking at females more than looking at males for one reason. How much time they take to sit down, how much time they take to get up. And even premenopausal women have low backache, joint pain. Why? The amount of lead in their blood from various sources, I will show you a few sources, are remarkable. Okay, now, this is the picnic garden in Calcutta. If you want to go for a picnic, please don't go there. It's only dumping lead oxide. The first company, British company, to manufacture excellent oxide started in Calcutta. That excellent oxide became X-ide. First 2 letters of excellent, last 2 liters of oxide, that battery company started. Of course, they said India moves on wheels, on battery. This is what happened when World Trade Center collapsed in US. They said, come and take whatever you want. Our people went, brought shiploads of cables, computer parts, wires to extract copper. They also brought a lot of lead, and many of them died even before they reached the half a century in their age. Here, there's a bakery, the battery repair shop, opposite to a girls' school in Bangalore, and we estimated, Professor Scott Clark was there, I'm also there, we estimated the soil lead content. It was very high. Children were coming there to eat buns and bread and cookies and cakes. They were all loaded with lead. Yellow. All school buses are yellow, even here, in Lucknow. Yellow paint has the highest amount of lead. Even today, if you spend 15% more, you can tell schools they can get lead-safe paint. Below 90 ppm, 90 parts per million. Government of India, or Bureau of Indian Standard has permitted 1,000, up to 1,000. It is not acceptable. That too on a voluntary basis. I collected the paint scraps from many of the buses. I found it was more than 40,000 ppm. Where is 90 ppm? Where is 40,000 ppm? Your sindoor is adulterated with lead and mercury. Turmeric is adulterated with lead chromate. School, playground. Yellow is put where children hold. Red has lower lead. At least they should have put red horizontal, yellow on the other sides where they don't come in contact with. We have an instrument called X-ray fluorescence. I'll send that X-ray fluorescence for 1 month to the university institution. It's 35 lakhs. Give a small project to your students. They can publish even a paper on how much lead is there in the wall, on the ground, on the playground. See, look at where did it yellow paint disappear? Children's body must have consumed, Levels of lead in Indian medicine. I don't want to call it as Ayurvedic medicine. Ayurvedic medicines are safe. Some traditional medicines, folk medicines contains lead, like including Chavanaprash, 7.3 microgram per gram. Supposed to make us active, Chavanaprash. It makes us hyperactive. Children particularly makes it hyperactive. Lead causes hyperactivity. And there are so many. Arogya Vardhini doesn't improve your arogya. It deteriorates. Forget about that level of lead in Middle East, Asian, African medicine. You know that henna, what we apply to hair dye, contains very high amount of lead. I ask people, especially old people who have dyed their hair, are you dyeing or dying? Hair dye is absorbed, the lead is absorbed by skin. Particulate lead from vehicular exhaust is directly absorbed by the lungs. Inorganic lead like lead chromate is absorbed by your intestine. Organic lead like hair, I'm not saying only hair dye, even lipsticks. Makeup material, why do you want to make up? There's a shortage of marks, teacher will make up. Shortage of attendance, principal will make up. Only if you have shortage of beauty, you should go for makeup. God created everybody beautiful. Why makeup? Why kill ourselves? Think it over for a minute. Look at levels of lead in Chinese medicine, Mexican medicine, Chinese medicine. If you want pure lead, 100% pure lead, no adulteration, no contamination, buy that Bobosane. It's sold in airports. In Bangalore airport, this is sold as a medicine for hyperactivity. Lead causes hyperactivity. But if you consume Bobosane, no activity, death. Mexican medicine, Grita. They put it on the tooth in the night. Morning they remove lead. To children, to make the teeth very strong. Aphrodisiacs contains lead. This one slide, I tell you, 5 years of study, one slide which was presented for 3 minutes, brought unleaded petrol to the country. This is the greatest data which could be summarized in nation level. 51.4% had their blood lead level high, increased in children below 12 years. Whereas in Bangalore, my state, only 40% because we did not have that many vehicles. But in Chennai, where petroleum refineries are there, in Mumbai, they were all very high. Anyway, we got rid of that. In past 12 years, 24 years, what happened? From 51.3%, it has come down to 34%. What are the alternative sources? You have many alternative sources. Tomorrow evening, I'm going for a wedding in Taj. They give me a plate which is on which there will be something printed. That print ink contains lead. Newspaper ink contains lead. In newspaper ink, you have all the pakoda, bhaji, samosa packed and given to you. Yesterday, I saw that newspaper was used to cover the food. We are not aware of this. There are many, WHO says it should be below 3 microgram per deciliter. Whom should we approach for knowing this? What are the symptoms of lead poisoning? Treatment for lead poisoning. What are the chelators? Where to get blood lead levels done? This information should be available to every citizen. In every district we should have facilities. Step taken to an organization which was established in this institution, in King George Medical University, is Indian Society for Lead Awareness and Research. I am extremely proud of all of you, this institution, madam. The National Institute, National Center for Lead Awareness is established here. Project leader, we teach teachers. The teachers go and teach children about lead, good and bad about lead. They are called leaders, lead educator. And also we have Project QPE, Quality Play Environment for Children. Playgrounds are given certification by this INSLA. And Project STEPS, Student Talent Environmental Projects. You, exploration project. Take it up. We'll fund it. Don't worry about the money. Economic damage, I told you. Every country has economic damage because of lead in their environment. Lead is in, if your petrol has to be unleaded, what about your child? Can we provide at least unpainted pencils to our children? Why should we give painted pencil? They use one end to write, other end to chew. You must have chewed the pencil. This is play equipment. You give a gift, go to child's house on the birthday, you give a gift, what do you say? Die soon. Because all these painted objects, when they put it in their mouth, what will happen? This is a typical Dashara festival all over the country. Poor people don't live long. This is the XRF, X-ray fluorescence. I told you 36 lakhs rupees worth equipment. You can measure the lead content without even touching it. And this is what the choice we have. Do you want the pencils, like one on the left, to be given to your child, grandchild, great-grandchild in your school? Or you want to give the pencil which is on the right side, which is not painted? Can we do that? At least in the state of UP, with your support, with your request, with your appeal, can we have state of UP schools not using painted pencil, unpainted pencil? Tirupati, I think you had been there, Balaji temple. The stones inside are joined with lead. They purchased 37 tons of lead to seal it in the night. When I went there, I first asked for a laddu to be tested, because the well water there, they wash it, same water goes there with lead. That well water is used to make that Tirupati Prasad, what is it? What is it called? Laddu, you know. I changed, it's not laddu, leddu. Lead content was very high. Thank you, friends, thank you.
Thank you, sir, for inspiring us. As we conclude, I would like to invite Professor Ajay Singh, sir, Professor, Department of Pathology, to conclude the session with vote of thanks.
A very good afternoon, everyone. I am honored to deliver the vote of thanks talk on behalf of Department Pathology at the time of Department of Pathology 113 Foundation Day celebration. And I want to express my sincere gratitude to our chief guest, Honorable Deputy Chief Minister, which is due to some busy schedule, which is not there, and our Honorable Vice Chancellor, ma'am, which is also some busy schedule not there. I would also thank to our Pro Vice Chancellor Ma'am, Professor Abhijit Kaur Ma'am, and our Dean Professor Amita Jain Ma'am for their presence. And I also deeply grateful to our distinguished speaker, Professor and HOD Pathology SGPGI, Manoj Jain Sir, and Professor Venkatesh Thupli, Director, Foundation of Quality Control in Bangalore, for sharing their expertise and insight with us today. Sir, your presentation were enlightened and thought-provoking and will undoubtedly improve our patient care. And I would also thank our dynamic Head of Department, Professor U.S. Singh Sir, and I would also thank our organizing team for their great effort for success of Foundation Day event. And I also thankful to media person for their coverage of this event. And finally, I would also thank our faculty member, student, staff, alumni faculty member for their participation and support, to success this event. Thanking you, finally thankful to all. Thank you, dear.
Let us now proceed for a group photograph capturing the essence of this memorable day.